E stands for expose and examine. So this is your quick head to toe. You can't treat what you don't find, and if you don't look, you're not going to see anything. So you have to expose your patient, get the clothes off of them, especially off of critical patients. Do this quickly. This is why we carry our trauma shears. So pull your trauma shears out, your big cool scissors, your EMT scissors, and cut the clothes off. Don't forget the patient's back. It's just as important as the patient's front. We just have to actually move the patient to get to it. And avoid delaying resuscitation while disrobing the patient. So this is where you're going to get extra help. Have a first responder help you cut the clothes off the patient while you're maybe assessing airway, breathing, circulation. Hypothermia. So hypothermia is kind of a big deal in trauma. We're going to maintain the temperature. I know we just talked about cutting the clothes off. We want to have a warm blanket close by. This seems silly. It always seems silly to me at first to have big warm blankets on ambulances in the heat of summer. Who really ends up hypothermic? Well, the answer is trauma patients and anybody who is in shock, actually. You have decreased perfusion, which means your oxygen is not getting to your cells. And remember, oxygen is used in the cells. It's combined with sugars, and you make carbon dioxide, water, and heat. So you have decreased oxygen, then you have decreased heat. And that's a problem. One of the things that happens here is that decreased body temperature will interfere with clotting. And if you have somebody who's bleeding internally, they need all the help clotting they can get. So a decrease in temperature is really a problem. Of course, you have lower ATP production to begin with, which is why you're losing heat, and then the low temperature is going to decrease ATP production on its own. So that's kind of a vicious cycle. What that means is that when you check your truck in the morning, make sure you have a blanket, and after you expose your patient, use that blanket on the patient to keep them warm. Even if you are sweating, throw a blanket on your patient. So at the end of your primary survey, where you're assessing for life threats, we've done the A, B, C, D, E. Now it's decision time. These are some load and go situations. So basically, these are the patients we want to get to the hospital quickly. They're the ones who are likely to need surgical intervention. Or something, anyway, that we can't do in the field. Intervention. Okay, good. I got that spelled right. So a head injury with decreased level of consciousness, they're going to surgery. An airway obstruction unrelieved by mechanical methods. Well, ALS may be able to help, or they may be getting a trach in the ER or in surgery. Conditions resulting in inadequate breathing. So this is something that we can help with, but ultimately we're going to get tired bagging them. We may not have enough help to bag them all the way. And using a BVM on your patient for a long time can be problematic. And by long time, I really mean more than about 20 minutes. And depending on who's squeezing it, maybe even less than 20 minutes. You fill up the stomach with air, you put pressure in the chest, and then that can affect your circulation. So anytime you have somebody with inadequate breathing, you want to get them to help somewhere that has a ventilator, basically, and a doctor who can intubate or a paramedic who can intubate. You want to get them help as quickly as possible. Shock. Well, there's some things that doctors can do and even paramedics can do that EMTs can't do, including IV fluids. Ultimately, these patients are going to need a lot of care. So if you have a patient who's in shock, especially related to trauma, that's a good indication that they're going to need to go to surgery. The other thing is basically conditions that are going to rapidly lead to shock. If you have somebody with a tender, distended abdomen, pelvic instability, or bilateral femur fractures, these are things that they may present to you looking okay right now, but they are going to crash on you pretty quickly. So these are load and go situations as well. And of course, any other issues you have with the ABCs. I certainly can't list every situation you're ever going to come across. You have to use your brain and figure out, is this an issue with the ABC that I cannot handle? And if so, I need extra help, and I need to load my patient up and go to the hospital. So with the primary survey, a blood pressure or an exact respiratory or pulse rate is not necessary to tell you that your patient is critical. Now, that doesn't mean that you want to skip vital signs. Eventually, you'd like to get some. So hopefully, we get some. Oops. Ran out of room there. Hopefully we get some. And if the patient looks sick or looks like he's really injured, then he is sick. So take him to the hospital. Your initial resuscitation for trauma patients, you're certainly going to treat as you go. You want to aggressively correct hypoxia, that's with oxygen, and inadequate ventilation, and that's going to be with a BVM. And control external blood loss. Direct pressure or tourniquet, TK. I know that's not how you spell it. You don't spell it with a K, you spell it with a Q. But the abbreviation for tourniquet is TK. So here are your steps. Mobilize C-spine. Keep the airway open, of course. Oxygenate. Rapidly extricate your patient to a longboard. Begin assisted ventilations with a BVM if you haven't already. You may be that your patient's pinned in and you're going to start bagging them while they're still in the car, if you haven't already. And don't forget the oxygen. Then expose your patient. Do your head to toe. Transport. So start transport, I guess. Start. And then reassess and report to the hospital en route. Consider requesting an ALS intercept. There are a few things that ALS providers can do. If you suspect your patient has a tension pneumo, that's something that paramedics can correct. If they have an airway issue that you're struggling with, paramedics have a little bit more training in airway. And then the other thing, if somebody's really hypotensive, those are things that you're going to want to consider ALS intercepts for. The thing is, though, ALS is not the end-all be-all. It may be really best for you to just go to the hospital. If it's going to cause a significant time delay to request and wait for an ALS intercept, it's best to really just go to the hospital with these patients. The goal here with the resuscitation is minimum time on scene and maximum treatment en route. Now, when you're considering additional resources, you may want to take some responders with you. Oops. So there's a lot of places that if you respond with a fire truck and an ambulance, that the ambulance can actually take some of the first responders with them in the ambulance to the hospital for some additional assistance with the patient.